When we think about strategies, we can really look at it from so many different angles because we can look at medications, right? And then how to use them, also dosing strategies, intervals. But I want to kind of focus on the broad strategies that professional and clinical guidelines really hone in on. So the two broad themes are multimodal regimens and also around the clock dosing. So with the first multimodal strategy, just to take a step back, pain is really complex, as we know. There could be a lot of biologic, genetic variables, subjectivity of pain perception per the individual, also different mechanisms that mediate pain. To really combat this, the guidelines like CDC, also the Department of Health and Human Services, they recommend and advocate for this multimodal pain management strategy. So this is essentially incorporating multiple medications and or non-pharmacological therapies to really target pain through various mechanisms. And this is really preferred because it helps reach our ultimate goal, which is to reduce morbidity, not only related to pain, but also morbidity related to opioid use. And then when speaking of the oral medications that's used in a multimodal regimen, really guidelines kind of mention, guidelines across the board mention some same analgesics, which are acetaminophen and NSAIDs. These are kind of the frontline. And then, these are very accessible medications, easily obtained over the counter. And also I wanted to talk about a study to support this. So there was this meta-analyses conducted by Abu Shanab et al. It was published in 2021, and they essentially evaluated the efficacy and safety of a fixed-dose combination of ibuprofen plus paracetamol, aka acetaminophen, against placebo. And the results of this study was essentially that patients receiving the multimodal option were able to achieve the primary endpoint, which was they were 2.6 times more likely to achieve 50% or more pain relief, and also reduced need for rescue medication and also longer duration until rescue medication was needed against placebo. So, acetaminophen, ibuprofen, these are over-the-counter medications. So for patients without any special conditions or comorbidities, these are also generally well tolerated, which makes them a pretty viable and compelling option. And then the second strategy that I mentioned was around the clock or scheduled dosing. This is essentially taking medications at a scheduled time instead of an as-needed approach. And this is also recommended across the guidelines, like I mentioned, CDC. There's also ASRA, ASA, also organizations like Agency for Healthcare Research and Quality, AHRQ. And to support this strategy, there was this study that was published in 2015. It was by Valentin et al. And they essentially conducted a retrospective patient chart review on women specifically who underwent cesarean delivery. And so the result of this was that scheduled acetaminophen resulted in fewer IV morphine equivalents than the as-needed group. So really all of this is to say it's really best to maximize the non-opiate strategies through two approaches, which is multimodal and the initial around-the-clock dosing, and then the PRN or as-needed approach later during recovery. Yeah, so there are medications that do kind of act closer to the surgical site or the peripheral nociceptors, and generally these medications are going to target some broad mechanisms, which are by reducing the inflammatory mediator production, also by stabilizing peripheral ion channels and nociceptor excitability, also by modulating local inflammatory or immune responses. So the first one that I mentioned with reducing inflammatory mediators, NSAIDs are going to be a primary example. So just to touch upon the mechanism, they inhibit the COX-1 and or COX-2 enzymes and then decreases the prostaglandin synthesis in the injured tissues. So this directly reduces the peripheral sensitization at the incision and also the surrounding tissue. So it doesn't just mask pain in the brain, and which is why they're so classic. And they're such an effective medication for classic post-operative nociceptive and inflammatory pain, obviously if the patient's not contraindicated. And then the second mechanism that I mentioned was by stabilizing the peripheral ion channels. And this is where I want to kind of introduce the novel first-in-class medication called suzetragene. And suzetragene is a highly selective NaV1.8 or NaV1.8 inhibitor. And so this specific sodium channel is expressed predominantly in the peripheral nociceptive neurons, and it's not expressed in the brain or spinal cord. So by disrupting the initiation and the propagation of action potentials, this medication, suzetragene, is going to reduce the pain signal transmission from the periphery to the central nervous system. And then the third one that I mentioned was to modulate the local inflammatory responses. And the medication that I'm thinking of is short course oral corticosteroids in select procedures. They do so because they reduce the local cytokine production, and then this decreases the inflammatory nociceptor activation at or near the surgical site. So they're not pure analgesics per se, but they can help change the local environment that generates pain. But I also really want to mention, I mentioned this in the previous question, but this is going to be a recurring theme of multimodal strategies. And the gold standard of multimodal strategy doesn't really choose between site of surgery versus brain, but they rather really try to layer both intentionally. So like I mentioned, the medications that could act in the periphery more so, but also medications that act centrally. So a primary example could be acetaminophen. This is one of the frontline medications, and the mechanism is not fully defined, but it likely involves reducing or weak central COX inhibition and then activation of descending serotonergic inhibitory pathways. There's a lot of postulations with the mechanism, but this is more of a central gating of pain rather than direct action at the incision. And there's also many other medications like gabapentinoids, SNRIs, TCAs, also non-pharmacological therapies like improving sleep or mood or cognitive framing. This really modulates the descending neurotransmitter inhibition and other central components of pain. So what we really want to take away from here is that we want to utilize medications that address both, right? So in the CNS, so centrally, and also medications that act near the surgical site or in the periphery. So this is going to really help reshape the patient's overall pain experience. Yeah, in terms of specialized options beyond over-the-counter ones, there are different specialized formulations or specialized medication classes. So examples could include fixed-dose combinations, prescription NSAIDs, gabapentinoids, newer medications, a lot of different options. But just to start off, the fixed-dose combination that I wanted to touch on is, I alluded to this earlier in a study, but an example is acetaminophen plus an NSAID. So for example, ibuprofen. And like I keep kind of repeating is the multimodal therapy. This is the gold standard, but in real life, it's really complex. You know, when you try to incorporate multiple monocomponents of medications that target different pain pathways, it involves for example, different dosing intervals for one medication, and also considerations like food. For example, one medication requires food with it, but then the other doesn't. So this overall is going to create a lot of complexity for the patients, especially when the majority of US adults have less than proficient health literacy. So FDCs or fixed dose combinations are going to really help simplify this by aligning the timing, also reducing pill burden. It just overall makes it more realistic for patients to stay on their around-the-clock therapy during the critical postoperative window. And then now going into more specialized medication classes, NSAIDs are one. So I know, you know, the ibuprofen, naproxen we see over the counter a lot, but NSAIDs is a huge class actually. So there's propionic acid derivatives or acetic acid, oxycam derivatives, and there's so many medications within that derivative classes, right? So prescription NSAIDs are being more deliberately used for short-term acute postoperative pain. And for example, meloxicam, celecoxib, oral ketorolac, these are only just some examples that offer stronger anti-inflammatory and analgesic effects than the over-the-counter doses. So today, pharmacists are really trying to deliberately use it and tailor it to the individual risk factors of the patients rather than just treating all NSAIDs as interchangeable. And then another class, I kind of alluded to this before, but gabapentinoids, it's really being discussed more recently because of the opioid sparing effects. So there was this really recently published meta-analyses in 2025. It was by Al-Muqad et al. And this study found that, although gabapentinoids didn't really have a clinically meaningful impact in pain in itself, the majority of studies they included, it did kind of support the opioid sparing effects because it reduced the opioid consumption. So generally, gabapentinoids are being more selectively recommended, more so for the opioid sparing effects than pain. And then lastly, the novel medication I mentioned earlier, suzetragene, I want to briefly touch upon this because the phase 3 trial was studied not just in any type of pain, but specifically postoperative pain. So specifically, they did 2 trials within. It was abdominoplasty and bunionectomy. So this is a more specialized class that can add optionality to the oral choices and for patients who exhausted other frontline options. So I know that was a lot, but just to recap, the fixed-dose combinations, prescription NSAIDs, gabapentinoids, newer medications like suzetragene, these are all some examples of specialized options that pharmacists can recommend to the healthcare professional team for postoperative pain management. A couple of things to think about with the effective plan in the first 72 hours to help chronic pain. So we can do so by trying to prevent the brain from learning pain through an early multimodal regimen, also by minimizing the opioid exposure, also by supporting the functional recovery. And this is a really good question because it's really important when you try to implement this early effective plan because it can determine whether a patient recovers smoothly or progresses towards persistent post-surgical pain. And if pain is not controlled during this early period, then, when the peripheral and central sensitization are most modifiable, then the nervous system can really undergo a lot of changes that make pain really hard to treat later on. So the first one that I mentioned was early introduction of multimodal therapy. So, to take a step back, if postoperative acute pain is uncontrolled, then it really increases the excitability in the dorsal horn and the CNS. So when you introduce this multimodal plan early, it can interrupt this process by reducing the volume and also the impact of the incoming pain signals. So this helps prevent the nervous system from quote unquote learning pain. And also another thing is implementing the early non-opioid regimen. This obviously is going to reduce the opioid exposure. So this in itself can lower the chronic pain risk because higher early opioid exposure is not only associated with prolonged post-operative opioid use, but also this thing called opioid-induced hyperalgesia, or OIH. This is basically when long-term or high-dose use of opioids paradoxically increase pain sensitivity and the risk of chronic pain. So a strong and then also early non-opioid plan can reduce the need for opioids in the first place, which reduces the opioid-induced hyperalgesia and then obviously in turn the risk for chronic pain. And lastly, another thing is that this early plan can support early mobility and functional recovery. This is because poorly controlled pain shortly after surgery is going to interfere with ambulation, a lot of things like sleep, even breathing exercises. So this is going to increase the inflammation, stiffness in patients, also fear avoidance behaviors in patients, which are all contributors to chronic pain development. So using this effective early regimen prevents the functional impairments and the development of chronic pain. So just to summarize, if we're able to maximize the first 72 hours by getting this multimodal plan early, reducing the non-opioid exposure early, and then, just help people get up and running, then we can really help patients from developing this chronic long-term pain. I think pharmacists are really important because they play a central and also increasingly visible role in helping patients manage their pain after surgery. Because, postoperative pain is extremely complex, like we know. Patients benefit from a healthcare professional who can easily translate the mechanisms, guidelines, real-world barriers into a practical plan. So just to delve into some of the examples, really pharmacists can be involved in the end-to-end process. So from pre-operative to post-operative, communicating with the HCP team. So we can first talk about the pre-operative side. So in this kind of part of the overall care process. Pharmacists can, specifically in clinical and ambulatory settings, can help patients understand what postoperative pain may typically feel like and what to expect regarding discomfort. Also ambulation, obviously medications, and also promote the safe medication use, especially since patients can be disoriented after surgery. And then postoperatively, pharmacists can perform medication reconciliation. Also, counseling is a big part. And they also ensure that the discharge prescriptions align with the evidence-based multimodal plans. They can also verify that the patients are not unintentionally duplicating therapy. A prime example is hidden acetaminophen in combination products. So that's something. And also, we can help clarify dosing schedules that can otherwise be confusing. And this part is also where pharmacists can recommend fixed dose combinations to really help try to simplify the multimodal therapy. And postoperative care also includes kind of transitions of care, right? So pharmacists can help deprescribe unnecessary medications, counseling, like I mentioned, and also ensure the safe transition from hospitals to homes. And then another process we could be involved in is monitoring. So pharmacists could monitor for various things like tolerability, adverse events of drugs, and then suboptimal pain control. Also, they could evaluate any patient-specific risk factors like renal or hepatic functions, drug-to-drug interactions, and then just ensuring that the high-risk agents like oral ketorolac are being used safely for the appropriate duration. So this kind of ongoing oversight really helps prevent the complications. And then last but not least, when we think of a healthcare professional team, it's really a unit, and pharmacists can really communicate and collaborate with the clinicians like surgeons or anesthesiologists, primary care teams to guide the appropriate medication therapy and also advocate for guideline-aligned multimodal therapy because we're the medication experts. So some examples could be helping select the appropriate NSAIDs, advising when adjuncts can be beneficial, also supporting opioid stewardship by ensuring the shortest effective opioid duration when opioids are still necessary. So overall, there are so many different areas that I mentioned, but pharmacists are really involved in the top to bottom overall care process. So this continuous intervention from a pharmacist is going to help potentially improve adherence, also reduce anxiety in patients, and just promote the overall safe medication use. One thing I want to add is, with this emphasis in non-opioid strategies, it's really from the opioid crisis. And, there has been a slight decline in fatalities of opioid-related deaths recently. There's still a huge opioid crisis demonstrating high death tolls driven by synthetic opioids specifically. And statistically, there's almost, 80,000 people that die every year from opioid exposure. There's also 76% of overdose deaths that generally involve opioids. And all of this is really a downstream effect of decades of opioid over-reliance, and post-operative opioid prescribing is one of the key gateways to long-term opioid use. So hence why strengthening this non-opioid strategy isn't just about better pain control in the first few days, but it's also really to prevent avoidable harm, to reduce exposure to medications that carry significant long-term risks, and also to really empower patients with a safer, more evidence-based option. And then one last thing I'd like to add is as our understanding of pain pathways evolve and as new therapies emerge, pharmacists are really important because they're uniquely and importantly positioned to guide the patients and the providers toward approaches that really help improve recovery while minimizing opioid use and the risk of chronic development.